Hello everyone, this is Dr. Abdullah Terkawi. I'm currently a pain management fellow at Stanford University. I'm happy to present to you these 4 lectures in perioperative pain management. And before we start, um, when I prepare these lectures, I was targeting both anesthesia and surgery providers. So I'm hoping both can get benefit from this. And the second thing I would like to mention, um, I was targeting um, areas with resource limited and underserved areas. So you will see I'm going to touch base during the course um, on medications that might not very commonly used in the US or in Europe, for example. Um, so the course will be 4 lectures, and during these 4 lectures, I'm going to take you through a journey. I'm going to first give you some background, explain to you the complex mechanism of pain and why it's important to treat pain, and then how we assess pain, how we predict people who will have severe pain or have used chronic opioid after surgery for a long time, and we're going to touch base on preventive analgesia. In the second lecture, it will be a pure pharmacology lecture. We're going to talk about the most commonly used opioid and non-opioid analgesics and touch base about few maneuvers for non-pharmacological pain management. Then the third lecture um, will give you an overview how to monitor this patient to receive pain management. Then we'll talk about special population who require special consideration when you treat their pain. For example, elderly, pregnant, obese patient. And then briefly, I'll talk about handling controlled drugs. The last lecture, we will put all the pieces together and we will see how we're going to treat patient for pain management. What medication we should give, what a route of administration, how we can create a plan for each patient, and how to will end up with specifically few recommendations for pain management in resource limited settings. So let's get started. So as probably most of you know that the International Association of Study of Pain define pain as unpleasant sensory and emotional experience associated with actual or potential tissue damage or tissue damage. The reason why I'm starting with this very simple and very popular definition, just to make everyone aware that pain is something that the patient experience. We should listen to the patient. The patient will be the best resource for you to know about the severity of the patient, where is the patient, and track your management. As you see here, this is September, and the IASP chose September from every year to raise the awareness among patients and providers and community about pain and pain management. So I'm using the hashtag here, Pain Management Month, and I'm also using the blue color that they choose for pain management. Just to let you know how important is this topic. Um, some studies showed that up to 60% of the emergency department visits, basically patients who were discharged with suboptimal pain management, they came back either because of poor pain management or as a consequences of poor pain management. So the goals of perioperative pain management are to relieve suffering, achieve early mobilization after surgery, reduce length of hospital stay, and achieve patient satisfaction. All work together. Successful pain control regime must take into account the medical, psychological, and physical condition of the patient. We should always think about the age of the patient, level of fear or anxiety, what's the surgical procedure, and we always discuss with the patient, share with them, and try to understand their personal preferences. What are the potential barriers to effective treatment of pain? Number one, inadequate patient education regarding pain and its management. Also, inadequate education for providers and administrators. Ignorance of proper pain management protocol and responsibilities. So before we dig in, I want to um, go over a few terminology with you. Um, when we talk about pain, sometimes we use nociceptive or somatic pain, neuropathic pain, visceral pain. And I think it's very important to know the difference between them because this will eventually help us in optimizing the pain management for each one. So somatic usually um, localized from the incision, from fracture, from wound, and it's usually sharp, aching, stabbing pain. Neuropathy is not that common during the first few hours or few days after surgery, but yes, subsequently become more common, and it's typically when a surgery involves a lot of damage to the nerve tissues. Patient usually presented with burning, shooting, and electrical pain. And lastly here, visceral pain, which is poorly localized. It's associated with underlying pathology in the abdomen or after surgery. So it's gnawing and crescendo pain. Let's talk about mechanisms of pain and why it's important to understand the mechanism of pain. The more you understand the mechanism of pain, the pathway of pain, it will help you in pain management. It will help you to make a proper plan and it will help you to explain to the patient. It will help you to optimize the treatment for the patient. So the generation of pain originates from the local inflammation and nerve damage typically associated with invasive procedure, trauma, and surgery. Then these processes result in the release of local mediators. For example, bradykinin, free radicals, histamine, serotonin. I'm going to talk about that in a minute. Nociceptors are sensory receptors that respond to these local mediators and send afferent signals toward the spinal cord and then to the cerebral cortex. So when we talk about pathways, we typically talk about afferent, which is the ascending pathway, the sensation, and descending pathway. Here, how the pain develop, and here how the body react to the pain. So there are three neuron important here, and we're going to talk about them more in the next slide. So the pain started here. Sensory receptors, A and C fibers, goes through the dorsal horn and ascend through the anterior lateral and the dorsal column, go to the medial lemniscal pathway system and all the way through the thalamus here and to the sensory cortex, dissociate at this level. On the other hand, this is the descending modulation, which is if it's activated correctly, it should help minimizing the pain. So this is the body reaction to pain. And as you see, it ends up by releasing a lot of substances that we're going to talk about in a minute. So in general, the ascending pathway, divided into 3 neurons. First order neuron, which is the periphery, A and delta and nerves and polymodal C fibers. The A delta fiber transmits the first pain, usually is sharp. Then the C fibers transmit the second pain, which is usually associated with affective and motivational aspect of pain. The second order neuron, which is here, the dorsal horn, consists of nociceptive specific and wide dynamic range neurons. The nociceptive specific neurons are located primarily in the lamina 1, respond only to noxious stimuli, and are thought to be involved in the sensory discriminative aspect of pain. The wide dynamic range neurons are predominantly located in laminae 4, 5, and 6, respond to both non-noxious and noxious input, and are involved with the affective motivational component of pain. Axons of both nociceptive specific and wide dynamic range neurons ascend the spinal cord via the dorsal column, medial lemniscus, and the anterior lateral spinothalamic tract to synapse on the third order neuron, which is in the contralateral thalamus, which then project to the somatosensory cortex in the brain, where nociceptive input is perceived as pain. The 4 elements of pain processing are transduction, transmission, modulation, and perception. Transduction is the event whereby noxious thermal, chemical, or mechanical stimuli are converted into action potential. Transmission occurs when the action potential is conducted through the nervous system via the first, second, and third order neuron, which has cell bodies located in the dorsal root ganglion, dorsal horn, and thalamus, respectively. Modulation of pain transmission involves altering afferent neuronal transmission along the pain pathway. The dorsal horn of the spinal cord is the most common site for modulation of the pain pathway, and modulation can involve either inhibition, which we all would like, or augmentation, which is a pathological reaction to pain. Examples of inhibitory spinal modulation include release of inhibitory neurotransmitters such as GABA and glycine by the intrinsic spinal neurons, and activation of the descending efferent neuronal pathway that I showed you a couple of slides before, which then result in release of norepinephrine, serotonin, and endorphins in the dorsal horn. However, things not always goes as we like. Spinal modulation sometimes result in augmentation of pain pathway, which manifests as central sensitization, which is a consequence of neuroplasticity. Phenomena of wind-up is a specific example of central plasticity that results from repetitive C fiber stimulation of the WDR neuron in the dorsal horn. And finally, perception of pain is the final common pathway which results from the integration of painful input into the somatory, sensory, and limbic cortex. Generally speaking, traditional analgesic therapy has only targeted pain perception, but with the new era, we would like to target all these four elements when we make a plan to treat pain. Chemical mediators of transduction and transmission, these are when tissue damage occurs following surgery, for example, it leads to activation of small nociceptive nerve ending in local inflammatory cells, macrophage, mast cell, lymphocyte, platelet. Um, anti antidromic release of substance P and glutamate from small nociceptive afferent result in vasodilation and extravasation of plasma protein and stimulation of inflammatory cells to release neurons. Numerous algogenic substances. These are examples of algogenic substance. For example, bradykinin, which is released from the macrophage, and it activates nociceptors. Serotonin, histamine, prostaglandin, leukotrienes, cytokines, neurotransmitters, and nerve growth factors. And you will see us, we gonna try to target these substances, antagonize them to optimize pain management. So when tissue injury tend to fuel neuroplastic changes within the nervous system, we call that neuroplasticity, which results in both peripheral and central sensitization. Clinically, this can manifest as hyperalgesia, which is defined as exaggerated pain response to a normally painful stimulus, as you see in this picture. Allodynia, on the other hand, which is defined as a painful response to a typically non-painful stimulus. We have two types of hyperalgesia. Primary hyperalgesia as a consequence of peripheral sensitization, and secondary hyperalgesia as consequences of central sensitization. So peripheral sensitization of polymodal C fiber and high threshold mechanoreceptor by these chemicals that I showed you in the previous table lead to primary hyperalgesia, which is defined as an exaggerated response to pain at the site of injury. As in the case in the periphery, the dorsal horn of the spinal cord contains numerous transmitters and receptors involved in pain processing. These classes of transmitter component integral to pain transmission include excitatory amino acid like GABA, excitatory neuropeptide substance P and urocinin A, and 3, the inhibitory GABA. The various pain receptors include NMDA, kainate receptor, and repetitive C fiber stimulation of the wide dynamic range. In the dorsal horn at this interval will cause the wind-up and central sensitization. This leads to secondary hyperalgesia, which by definition is an increased pain response evoked by stimuli outside the area of injury. So why it's important to treat pain? Inadequate relief of postoperative pain has proven to increase the mortality and morbidity. It delays patient recovery, increase the cost, and decrease patient satisfaction. Importantly, also it has been shown to increase the risk of persistent postoperative pain, which I'm going to talk about. In specific situation, for example, after C-section, poor pain control can affect breastfeeding and subsequently can lead to postpartum depression. So because of the importance of the pain management, Jaco decided that pain should be the fifth vital sign. And all institutions seeking accreditation from Jaco must develop pain management programs. So when we look at system by system, poor pain management can cause tachycardia, hypertension, increased cardiac workload, and subsequently myocardial ischemia and infarction. Respiratory, if you have pain, you cannot take a deep breath, you cannot cough up, you may develop atelectasis, hypoxia, and even pneumonia. GI, it's well known to slow down the bowel movement. Renal, it increases the risk of urinary retention. Coagulation increases the risk of thromboemboli, even it impairs immune function, and it increases the risk of thromboembolism. The psychological aspect, it can precipitate to anxiety, frustration, and in children, undermanaged postoperative pain might lead to prolonged, up to 1 year, risk of changes in behaviors. So this is a recent study. They looked at almost 1,000 patients who underwent different surgical procedures. And they looked at the incidence of pain or bad pain and how it affect outcome after surgery and complication within 30 days. So they found out that moderate pain with movement, which defined by score between 4 and 7, occurred in almost 40% in the first day, and it decreased, but not huge decrease in the second and third days. Severe pain, 16% the first day, 10 and 6. Overall, almost 70% of patients reported unacceptable pain at least once in the course of the first 3 postoperative days. Postoperative complication was defined by the author as any medical adverse outcome occurred between admission and 30 days after operation. Having postoperative pain was assessed in 2 ways. As I mentioned, movement evoked pain on the numerical rating scale and the patient opinion whether the pain was acceptable or not. These are some results from the study. So, values to the right of the vertical line represent a positive association between pain and complication. And as you see, those who develop moderate to severe pain, they all, except 2RB, and have a statistically significant increase odd ratio of having complication. Those who reported unacceptable pain, also the odd ratio, the log odd ratio increased, favoring developing more complication. Indeed, NRS pain scores is on average increase it, and unacceptable pain at least once during the course of the first 3 days after surgery increase the pool as well. Let's talk about how we're going to assess pain. We so far understand the mechanism of pain, risk factors, and what are the consequences of bad treatment of pain. So now how are we going to assess pain? So remember, the first thing I started with, pain is subjective component. So the assessment of pain and the treatment of pain rely heavily on the use of self-reported pain scale. We have multiple examples. Probably one of the easiest way to use the numeric rating scale, you just ask the patient, would you please rate your pain for me from 0 to 10? 0, no pain, and 10, worst pain possible. This is a flyer from Penn University. They developed this for patients. And first, they show them how to rate their pain. It's important to educate the patient even before surgery and explain them the language that you're gonna use to communicate with them after surgery to assess their pain. What does it mean 0 to 10? So from 0 to 3, usually it's mild pain. From 4 to 7, it's a moderate pain. And from 8 and above, severe pain. And each one should trigger different response for pain management and different strength and doses and route of access. Proper diagnosis of the type and intensity of pain is crucial for adequate and targeted treatment of acute pain. The patient should feel sufficient empathy on the part of healthcare professionals. The examination of acute pain should include medical history. You should know the history of the patient, you should examine the patient, and you should, factors affecting postoperative pain, you should look for intensity, quality, duration, and these are the factors that affect them: the location, duration, type of surgery, physical and mental status, preoperative psychological and pharmacological preparation, type of anesthesia, pain management before and after surgical procedure, incidence of surgical complication, and quality of postoperative care. So again, and I would like to stress on this because most of us, when we go and ask the patient about pain, we find the patient lying in the bed, ask them, okay, how's your pain? Then the patient say 3 or 4. But I'm also interested to know what's their pain during movement, breathing, coughing, and bowel movement. These are important and these are determinant of recovery. So if I'm doing a good job in pain management, I should also ask the patient about this and make sure the patient can move, breathe, cough, not only lay in the bed comfortably. So when we look at the table here, feature of pain commonly addressed during assessment, look at the onset of pain, pattern, site of pain, radiation, quality, intensity, exacerbating factor, relieving factor, respond to analgesics. Look, what are the pain management that the patient received, what did help, what didn't help. Respond to other intervention, associated physical symptoms, associated psychological symptoms, and how the pain interfere with the activity, the daily activity, as I mentioned. And then you have to do a thorough physical exam and with a particular attention to the neurological status, such as the consciousness level. Is the patient sedated? Is the patient awake? And look for any indicators of nerve injury, anything that indicates neuropathic pain, for example, which will be a quite differently treating. Let's shift gear now and talk about risk factors and predictors of severe postoperative pain and chronic opioid use. Predictors of postoperative pain usually Preoperative pain, existing preoperative pain, and anxiety, young patient, obese, surgical fear, catastrophizing, and type of surgery. We know like big abdominal surgery, major orthopedic surgery, thoracic surgery will definitely be more painful than, for example, lap epi. So the type of surgery, the age of the patient, the psychological distress, all are predictors of postoperative pain and analgesic consumption that we should consider when we making a plan for pain management. I mentioned to you earlier the chronic post-surgical pain, which is defined as pain that persists at least 3 months after surgery, pain not present before surgery or that has different characteristics or increased intensity from preoperative pain. Pain is localized to the surgical site or a referred area. Other possible causes of pain are excluded: cancer recurrence, infection. Roughly the incidence about 10% from all comers, all surgeries. However, the type of surgical procedure influences both the incidence and severity. They are more common in thoracotomy and breast surgery and knee arthroplasty. Potential risk determinants of persistent post-surgical pain can be divided to preoperative, intraoperative, and delayed postoperative. Preoperative, for example, anxiety, catastrophizing, depression, genes, and other stressors. During surgery, nerve injury, tissue ischemia, surgical technique, anesthesia technique, and after surgery, postoperative pain, hyperalgesia, if the patient received radiotherapy, chemotherapy, and psychological factors. This is one of the big database studies where the authors looked at almost 36,000 patients who underwent either minor or minor major surgery. And the sampling criteria was they looked at people who had no opioid prescription prior to surgery and those who had, and follow them all the way up to 3 to 6 months after the surgery. If any patient at that time taking one or more opioid, then they define that as new persistent opioid use if they were not using before surgery. So they found that the rate of new persistent opioid use were similar between the two groups, interestingly, and on average you have about 6%. So 6% from all your patients may end up using opioid for long term. This is not an easy number. So if you are giving anesthesia or doing surgery for 100 patients each month, then 6 of them will be using opioid for more than 3 months or more than 6 months, compared to those who did not have a surgery, which is 0.4. So surgery per se, it's a very important factor to trigger opioid dependence. And it's a very important time to work hardly to minimize this risk, minimize the risk of addiction, and participate in what we all hear about nowadays, the opioid, to avoid the opioid crisis that we all hear about nowadays. So they also looked at risk factors independently associated with new persistent opioid use, which are tobacco use, alcohol and substance abuse, mood disorders, and anxiety, preoperative pain, and centralized pain. This is another study from Stanford, and in this study, it's a huge study. They looked at more than 2 million patients. And they also looked at the incidence of chronic opioid in the first postoperative year. But this time, they defined the opioid use here quite differently than the first study. While the first study, they took anyone who is using any opioid regardless of the dose. This was more strict criteria, so they looked at certain dose and certain number. So they found at 1.4. So this is more preservative. But if you want any patient who is taking any opioid at regardless of the dose, then it's about 6%. The baseline incidence of chronic opioid use among the non-surgical patient was way less than 1%. To the top right here, you will find the incidence of chronic opioid use among opioid-naive surgical and non-surgical patients. And here you find some risk factors of chronic opioid use following surgery. They found that male 6, age older than 50, and preoperative history of drug abuse, alcohol abuse, depression, benzodiazepine, or antidepressant were all associated with chronic opioid use among surgical patients. I'm gonna finish my lecture today with a very important concept that's sometimes confused. People often confuse preventive analgesia with preemptive analgesia. Preemptive analgesia used to be the idea in the past, but new research replaced the preemptive analgesia concept with preventive analgesia. So preventive analgesia include any anti-nociceptive regime delivered at any time during the perioperative period that will attenuate pain-induced sensitization. So basically, you are preventing pain-induced sensitization. The term preventive analgesia replaced the older terminology preemptive analgesia, which defined as analgesic regime that is administered prior to surgical incision and is more effective at pain relief than the same regimen administered after surgery. It is a common practice among many anesthesiologists in different areas in the world. When they induce the patient, will give some fentanyl, give some morphine up front, assuming that this will prevent pain, and this is the concept of preemptive analgesia. However, as I mentioned, now we should think about preventive analgesia, which can be happen at any time during the perioperative pain, and it should target pain-induced sensitization. So the goal of preventive analgesia is to block the development of sustained pain. Theoretically, this occurs by preventing NMDA receptor activation in the dorsal horn that is associated with the wind-up, facilitation, central sensitization, expansion of the receptive field, and long-term potentiation, all of which can lead to chronic pain state. In order for preventive analgesia to be successful, 3 critical principles must be adhered to. 1. The depth of analgesia must be adequate enough to block all nociceptive input during surgery. 2. The analgesic technique must be extensive enough to include the entire surgical field. And 3. The duration of analgesia must include both the surgical and post-surgical period. Patients with pre-existing chronic pain may not respond as well to this technique because of pre-existing sensitization of the nervous system. And if you look at this, you will think, probably regional analgesia is the best available method that can be satisfying all these three, but we're going to talk about in the next few lectures. These are my references, and